I think it's time for us to get going here with our lunch symposium. I want to say thank you very much to Boston Scientific for setting this all up. And thanks to everybody for spending their lunch time with us here. It is my distinct pleasure to introduce Professor Marianne Brodmann. Professor Brodmann is a medical specialist in angiology and internal medicine at the Medical University of Graz, where she also serves as a substitute head of the Division of Angiology. The professor has been a member of multiple groups, such as Nucleus Working Group Peripheral Circulation of the ESC and Nucleus DVG and Nucleus OGIA. She served as secretary and chairperson of the Working Group Peripheral Circulation of the European Society for Cardiology and was the president of OGIA from 2012 to 2014, as well as the president of the European Society of Vascular Medicine from 2017 to 2018. She's also been a national delegate of the International Union of Angiology since 2005. So Professor Brodmann's research interests include anticoagulation of thrombolysis, new endovascular technologies in the peripheral field, and evaluation of nature of restenosis and ISR. Additionally, the professor has participated in multiple international clinical trials. She is the principal investigator for Restore ATK, and it's again my distinct pleasure to introduce her up for her lecture.
Yeah, thank you very much for this really kind introduction, and I'm also very much pleased to be able to talk about this new endovascular laser-assisted technology. And as you already have pointed out, I'm always interested in the new things, not in the old ones, because the new things are interesting, and this is what I'm really interested in. So the SEISMIQ intravascular lithotripsy system, with regard to design goals, it's a next generation IVL platform designed to provide an enhanced user experience. Compared to others, it's able to deliver more energy per pulse, has a high deliverable catheter, has a consistent acoustic energy, and has also improved emitter visibility, as you can see here. And you can, which is a very, very outstanding thing, and we were really the first users of this kind of technology, is that you can turn off and on the emitters. So you do not have to use all the emitters at the same time. So when you want to concentrate, especially maybe on such an eccentric calcification point, you can just shut down all the other emitters and just concentrate on these two. And you also get real-time feedback. So the mechanism of action is it converts laser energy to acoustic pressure waves by generating a plasma event within the balloon. And you can see here how this bubble is created. And the unique feature of this SEISMIQ intravascular lithotripsy system is that this bubble is covering the whole vessel wall, and it's not just hitting a special point. And therefore it really pressures, the initial pressure waves fracture the calcium, and the secondary cavitation bubble expands the fracture. And this is a unique mechanism of action, and you can also see it here on this video how it works. And this is really an outstanding technology. So with regard to Restore above the knee, this is the trial I want to start first. The objective was to evaluate the safety and the efficacy of the system for the treatment of calcified lesions in above the knee. It was a prospective single-arm multi-center trial. We had 95 sites in Austria, Germany, and Croatia. We treated a Rutherford classification 2 to 4 and target lesion in de novo SFA or popliteal artery of more than 70%, up to a lesion length of 150 millimeter. The reference vessel diameter was 3.5 to 8, moderate to severe calcification on the angiogram. And the study device, you can see here, the length was 60 millimeter at that time for the device, and the diameters ranged from 3.5 to 8. Primary endpoints were safety, freedom from major adverse event within 30 days following the index procedure, It was a composite of DEF, clinical-driven target lesion revascularization, and unplanned target limb major amputation. And with regard to efficacy, it was a residual diameter stenosis of less than 50% with or without adjunctive PTA therapy and or stenting. And it was core lab assessed, and the follow-up was up to 6 months. So with regard to the clinical characteristics of these 95 patients, the mean age in a claudicant cohort was, mainly claudicant cohort, was 70 years, also a good number of females, and these are the usual risk factors you see here as we face in patients with claudicants. With regard to the lesion characteristics, we mainly treated the SFR, but also the popliteal artery, with a mean reference vessel diameter of 5.5. We also treated 1/3 of our patients and our lesions with CTOs, and the lesion length was up to 10 centimeter. And what was really outstanding was the severe calcification, and this is core lab eradicated. 93.7% of our lesions in this trial were severely calcified lesions. With regard to the procedural details, pre-dilatation was done in around 26% of the patients. We were able to successfully deliver our IVL catheter in all the patients. We did some kind of post-dilatation, around 18%, and the stent rate was really low, only 3.2%. So the primary efficacy endpoint was met with a residual diameter stenosis of less than 50% in all the patients, and we had a really good mean acute luminal gain of 3.5 plus minus 0.9, and the rate of dissections, especially the severe one, was really rather low. So no cases of perforation, distal embolization, abrupt closure, no reflow or dissections meeting the SAA criteria. So primary endpoint at 30 days, freedom 100% freedom from major adverse event at 30 days. The follow-up was complete at 93 patients. At 6 months it was 92. We had 0 deaths, 0 clinical driven target limb revascularization, and 0 target limb major amputation. With regard to the primary efficacy endpoint, residual diameter, as mentioned, less than 50%, 100%, and the target lesion patency at 30 days, 98.9%, and at 6 months, 7.5%. And this was also shown by a significant clinical improvement from baseline, which was statistically significant. The RESTORE below the knee study, Michael Lichtenberg was the PI. The purpose was to evaluate the safety and efficacy of the SEISMIQ IVL system for below the knee lesions. Once again, prospective single-arm multi-center study. The patients were included in Austria, Germany, and in Lithuania. 20 patients were included. Once again, Rutherford 2-4. Target lesion, de novo tibial arteries with more than 70% stenosed, and the lesion length was up to 150 millimeter. And the lesions needed to have moderate to severe calcium. Primary endpoints, the same with regard to safety, freedom from major adverse event within 30 days following the index procedure, composite of DEF, clinical driven target limb revascularization or unplanned target limb major amputation, and with regard to the efficacy, the procedural success, acute reduction in diameter stenosis of the target lesion, and this was once again core lab eradicated. So coming to the patient and lesion characteristics, out of these 20 patients, below the knee disease, the patients were older, a mean age of 73 years, and the rate of the percentage of patients with diabetes was higher, 75%. So I think this is very important to show. We also had, with regard to Rutherford category 3, with regard to Rutherford category 3, 30%, 4, 5%, and 5, 65%. Lesion characteristics of these 20 lesions. We mainly treated the anterior tibial artery, but also the tibial peroneal trunk. And with regard to the diameter stenosis, really high-grade stenosis and also a high percentage of CTOs. The lesion length was around 7 centimeter, and with regard to severe calcification, once again, a high rate of severely calcified lesions, 80%. With regard to procedural characteristics, we did pre-dilatation in a very low number of cases, so this shows the really good deliverability of this system. To be honest, this was especially in the below the knee space very, very eye-opening. And post-dilatation needed only to be done in 3 patients, and we did 0 stenting. The primary efficacy endpoint was met, and there were once again no cases of perforation, distal embolization, abrupt closure or reflow, no other sections meeting the SAE criteria. With regard to the final lesion characteristics, so we had this acute reduction in percentage diameter stenosis to 47.5%, and the acute gain was 1.3 millimeter, and we had non-dissections in below the knee disease lesions with severe calcification. So primary endpoint at 30 days, 100% freedom from major adverse event at 30 days, was met for TEF, clinical-driven TLR, target limb major amputation, so 0 at 30 days. With regard to efficacy endpoint, with regard to acute reduction in diameter stenosis, as I have mentioned before, this was met 47.5, and the residual diameter stenosis less than 50% post-treatment was reached in all lesions in 100%, and we also could see a significant clinical improvement with regard to Rutherford category. So the conclusions out of these both trials, the primary safety endpoints were met with no major adverse events through 30 days. We had no unanticipated or serious adverse device effects through 30 days, and we had an extremely low rate of vascular complications. The primary efficacy endpoints were met with a procedural success rate of 100% with low residual stenosis, and these trials demonstrated the safety and efficacy of the SEISMIQ IVL system for the treatment of calcified and stenotic lesions. Thank you very much.
Thank you. Thank you, Professor. If anybody has any questions, please come up and the microphone's there. I'll just get this started. I think, of course, is the first real contender in the IVL space compared to what's currently available. It's very nice to see that it was delivered 100% of the time. And particularly in the BTK section, a lot of the treatment was 50% was anterior tibial. So taking that curve and being able to kind of pass that can tend to be challenging currently. So can you, I know you commented a bit, but maybe if you could expand a little bit on how you feel the deliverability of the devices currently and if you're comfortable with that.
This was the so-called first generation, or is a first generation device. So you're always very curious how this will work. And so this was really, for me and also for my colleagues, in the cath lab, very eye-opening and very surprising. It was just, flushing through, especially with these highly calcified lesions. And also when you look at the curve of the tibial, anterior tibial artery, we didn't have that, we didn't see that. So we were really very, very surprised and very happy how the deliverability was. And this was really one of the outstanding things right away from the beginning, before we knew the efficacy and the mode of action and
yeah,
whatever.
because if you can't get the device to the site of the pathology, then you can't treat it. So that's always challenging. I mean, a very low rate of pre-dilatation and very effective in that regard. you know, for the ATK trial, the Restore that you're the
Yep.
PI on, why did you select, or why was it selected less than 50%? You know, usually for the success of the angioplasty, you know, usually we worry about 30%. And so, was there a particular reason for that, or?
The 50% was just, chosen in comparison to other trials and other technologies in the market. So this was the reason why. So we wanted to compare that, and this was the reason why we did that right away from the beginning. And I also want to highlight some other features of this technology. So you have a really high number of pulses you can use during the procedure. It's really unlimited, I would say, especially if you have these long calcified lesions. You can treat with one kind of catheter these long lesions in an efficient way, and this is really outstanding. And this is right now what we have as the first generation. So if the number of pulses, you just plug the catheter in, and you have up to 600 pulses, and this is incredible.
You also highlighted in your couple of earlier pictures that you don't have to use all the emitters. You can select which ones that you want in order to really focus that acoustic wave on that part of the calcium. Have you used that feature yet?
We use that because I also used some kind of other technologies, and with regard to this, first in human, with regard to this, when you compare patients right now to patients we treated before with calcium, you see that, especially in this cohort, we really had 90% above the knee, more than 90% severely calcified lesions. And the calcium also has changed. The lesions have changed. It's more eccentric. And in these eccentric lesions, it was so comfortable just to shut down the emitters and just focus the 2 emitters or 3 emitters on the spot where you need the energy. And this really had an impact. And this was visibly right away on the cath lab table, and the core lab then said that this was really the difference with regard to the outcome at the end of the day.
And for you, generally, or the way you see this moving forward, you expect this to be a standalone therapy, or you still think this is going to be adjunctive or vessel prep in addition, in preparation for maybe DCB or something else?
I mean, it's a vessel prep technology. Yeah. So that's the one thing. And I think adjunctive therapies, we have a lot of adjunctive therapies, TCPs, drug-eluting stents, whatever. But as a vessel prep system, I think it's a standalone therapy. And I do not see, especially in these calcified lesions, right now with the experience we have with this technology, the addition of something else.
Yeah, from your lecture earlier today about when you choose IVL versus atherectomy, particularly in below the knee, you think that this will probably, IVL technology will probably be the go-to technology for severely calcified, particularly smaller vessels? In my opinion, yes. And, when we also overlook the patients we have treated. We follow them up on a regular basis. It's even if the study period has come to an end, the patients are coming back not because they have symptoms, but because we want to look at them, and we see that there's really a difference with regard to other technologies we have used. So with regard especially to clinical driven TLR. Yeah, fabulous. I mean, the data obviously speaks for itself, both in the ATK and the BTK space. From the mechanism of action that you saw, they says the acoustic wave is powerful, if you will, and there's a secondary cavitation. I know initially with initial use of IVL, people were worried about maybe will there be a distal embolization? Do you have to use a filter, et cetera, et cetera? Is that still something that's on your mind? I mean, I know the data does not show that, but I think maybe for the people in the audience, sometimes people worry about that, and if you could just tell us your experience. No, I was also a first in human user or second in human user for another IVL technology, and there was this question about having distal embolization, and I was talking to a colleague in
New Zealand, and he was using filters, and he's showing me that there's no debris in there, and said, I don't have the filters available. I said, okay, you don't have to use them. So we didn't see that. It's just, you know, an anecdote, but we do not see this kind of low flows phenomenon or whatever. So, and even if you use the beetle acceleration time, just, you know, to see how this has improved, you see that it's really efficient, and they do not have any kind of fear for, you do not have to have any kind of fear of some kind of issues which might occur. For sure not distal embolization. You also see that the dissection rate is so low in this heavy calcified lesion, 90%, around 90% of calcified lesions. Look at the severe the severe dissection rate.
Yeah, I mean, it's the rate of bailout stenting is practically negligible, and the rate of dissection is very, very low. I'm sorry, yes, please.
For the BTK interventions, were they done up and over for all cases or antegrade, and what platform did you use, a 6 French, 7 French system, or did you have any retropedal interventions?
In this 20 patient cohort, we just went antegrade. This was just, you know, at that time. I mean, right now, with the profile of the system, I would also say retrograde is a possibility, and you can do it. But for the study, we did it antegrade.
So what? You know, because it's a laser-based technology, the energy comes, you know, a little bit different than other technologies where it might be easily in the room. They have to bring like a power supply. How do you find that changed anything for you in the use of the room, or no?
The engineers are great, to be honest. So they changed it from the larger one to a very comfortable power supply right now, and this was really done, I would say, in a very short time. So right now I don't see any kind of issue that I have this console and I use this kind of system compared to others. So for me that's not, and if it's efficient, especially in these highly calcified lesions, the size of the technology is not relevant for me.
Agreed. And actually, I want to touch up on that. With the efficiency, you said that it's practically unlimited amount of waves that you can send. But how many times do you feel like you're using a lot? Do you feel that you have to consistently, you know, use or deliver more waves to get the result that you want? Or you feel like it's relatively, I guess, efficient's the right term is what I'm looking for.
The point is, when we compare it right now to what we use in daily life, we need a second catheter to achieve the same result. Maybe I can explain it in that way, as we achieved it with the SEISMIQ technology in this really severely calcified patient. More than 90% with regard to Park's criteria, severely calcified patient. So this was a selective patient cohort. And in daily life, in this kind of patients, in comparison, you need a second catheter.
Right, right. So just to be clear, so with what's currently available, you feel you need more than one catheter to achieve what you can achieve with the SEISMIQ using the one balloon catheter.
And the engineers told me that they can increase the number of passes.
Oh, even great.
Up to what level we want, so this might not be the limitation.
So, you know, again, I think, you know, you commented a bit on deliverability, because I think that's important. Currently, for particularly BTK, we see highly calcified, either intimal or medial calcification, and as was adjudicated, obviously, with high PAX criteria, you know, still, you find, I know in the trial, you know, the need for pre-dilatation was very, very low, but even the distal tibials, like I said, you find that the catheter really kind of can get there without much supplementary.
We really went very, very down to the ankle, so there was not an issue. Sometimes we tried to go as far down as possible just to see how it works, because this is usually the case in this first-in-human studies, just to you really want to do and to prove and to see what this kind of device can do.
Okay, great. Any other questions? No? I also want to touch a little bit on, you think at some point with the after the use of it, do you find that there's any decay because of the power? So let's just say you're using the wave and you're getting the good result, but if you're, let's say, using it longer or you're re-advancing the catheter, do you feel like you're getting less of a power when you're using it more?
No,
Okay.
no.
Okay. Fabulous. I invite anybody else for any other questions. I feel like I'm grilling here the professor, and we have her here if anybody has any other questions. Has anybody seen this? Well, they haven't seen it yet, I guess, since it's not currently commercially available in the U.S. yet. Not yet. But the plans for it to come down. Okay, well, fine. With that, if there's no other questions, I think I'll let everybody get their lunch back. Thank you again, Professor.
Thank you.
Very much, okay?